Welcome to this comprehensive lecture on metabolic encephalopathy and metabolic coma. Today, we will explore one of the most challenging and clinically important syndromes in neurology and critical care medicine. Metabolic encephalopathy represents a spectrum of global cerebral dysfunction that ranges from mild confusion and delirium to profound coma with decerebrate posturing. Unlike structural brain lesions that damage specific brain regions, metabolic encephalopathy affects the brain's function globally, making it both more reversible and more diagnostically challenging. Throughout this presentation, we will examine the clinical presentations, understand the underlying biological mechanisms, master the diagnostic workup, and learn evidence-based management strategies that can restore consciousness and prevent long-term complications. Metabolic encephalopathy is fundamentally a syndrome of global cerebral dysfunction. What distinguishes it from other causes of altered consciousness is that it occurs in the complete absence of structural brain lesions. The clinical presentation exists on a spectrum beginning with very mild confusion and progressing through various stages of delirium characterized by impaired attention and fluctuations in alertness to eventually deep coma with decerebrate posturing. The key anatomic feature is diffuse bilateral cortical dysfunction rather than focal pathology. This is clinically significant because it explains why cognitive function in conscious patients typically fluctuates considerably, sometimes dramatically, throughout the day, a feature that distinguishes metabolic encephalopathy from progressive dementias where cognitive decline is steady and relentless. The treatment approach is fundamentally different from structural lesions. We focus on identifying and correcting the underlying metabolic derangement, providing supportive care, and importantly, avoiding sedating medications that can worsen the encephalopathy. To understand metabolic encephalopathy in its modern context, we should briefly acknowledge its historical development. In 1960, Glaser first described the clinical manifestations of encephalopathy occurring in the setting of renal, pulmonary, and hepatic disorders, characterizing them as acute and chronic disturbances of intellectual performance and motor and sensory activities. This foundational work was followed by Plum and Posner's seminal classification, which divided encephalopathy into two distinct categories, structural and toxic metabolic. Their comprehensive monograph, The Diagnosis of Stupor and Coma, became the gold standard reference and shaped how we approach altered consciousness to this day. In contemporary clinical practice, we define metabolic encephalopathy as global cerebral dysfunction occurring in the absence of CNS structural lesions, manifesting as delirium or, in more severe cases, coma. Importantly, our modern definition specifically excludes certain conditions that might otherwise be considered metabolic in nature, such as metabolic encephalopathies from inborn errors of metabolism, cardiac arrest, anoxic-ischemic injury, direct CNS infections, exogenous toxins, hematologic conditions, immune-mediated diseases, and the direct or indirect effects of cancer. This precision in definition helps us focus on the conditions we can most effectively diagnose and treat. The clinical presentation of metabolic encephalopathy typically begins with delirium, which is often the earliest recognized manifestation of brain dysfunction. Delirium is characterized by a profound inability to focus, sustain, or shift attention, accompanied by fluctuations in alertness and clouding of consciousness. Patients often show disturbances in their normal wake-sleep cycle and may exhibit agitation and restlessness. At the bedside, we can rapidly assess for delirium using several simple but effective tests. We ask about orientation to self, place, and time. We test digit span both forward and reverse. We ask patients to spell world both forwards and backwards, which is surprisingly sensitive for detecting cognitive impairment. We have them recite the days of the week and months of the year backwards. We perform serial 3s and 7s, and we perform vigilance A tasks, where we ask the patient to tap whenever they hear the letter A in a sequence we recite. These bedside tests take only minutes, but provide valuable objective evidence of cognitive dysfunction. Beyond attention, we also observe psychomotor abnormalities. Some patients display hypoactivity, decreased motor activity, reduced alertness, and minimal speech production. Others display hyperactivity, increased motor activity, tremor, purposeless movements, restlessness, and agitation. Many patients display both patterns, alternating between hypoactivity and hyperactivity throughout their hospital course. Understanding these presentations is crucial because they influence how we manage and monitor our patients. As metabolic encephalopathy progresses beyond delirium, patients enter stages of increasing consciousness impairment. Obtundation represents the first stage of this progression. Obtunded patients are withdrawn and lethargic. They require verbal stimulation to open their eyes and reorient their attention. They can follow commands, but often unreliably. After examination, they withdraw back into the lethargic state. Stupor represents a more severe stage. Stuporous patients require noxious stimulation such as sternal rub or nail bed pressure to promote eye opening. They quickly withdraw back to a depleted state of consciousness. Focal neurologic findings are typically absent, though patients may show limited participation in the examination. Finally, we reach the comatose state. Comatose patients present with complete inability to stimulate eye opening, whether through verbal or noxious stimulation. They may have associated respiratory depression and upper airway obstruction. In some patients, the examination may remain non-focal, helping us distinguish metabolic from structural causes. However, this distinction can be challenging. Patients commonly have associated airway compromise and cardiovascular abnormalities, necessitating urgent triage to a critical care unit. The key clinical point is that while these stages represent increasing severity, they are often reversible if we identify and treat the underlying metabolic derangement promptly. One of the most important clinical skills is distinguishing metabolic encephalopathy from structural brain lesions, as this distinction fundamentally changes our diagnostic and therapeutic approach. Several key features help us make this distinction. First, consider the acuity of presentation. Structural lesions like trauma, subarachnoid hemorrhage, or ischemic stroke typically present with acute onset of symptoms that remain relatively static. Metabolic encephalopathy, by contrast, typically presents more subacutely and is characteristically fluctuating in nature. Second, examine the clinical setting. With metabolic encephalopathy, there is usually an overt metabolic derangement, background of vital organ dysfunction, recent medication administration, or evidence of systemic illness. Third, look carefully at the general examination. Clues include jaundice suggesting liver disease, hyperventilation suggesting metabolic acidosis, signs of chronic pulmonary or cardiac disease, hypothermia or hyperthermia. These findings point strongly toward metabolic causes. Fourth, pay close attention to vital signs. Specific vital sign abnormalities correlate with underlying pathophysiology. For example, myxedema coma and Wernicke encephalopathy commonly cause hypothermia. Thyrotoxicosis causes hypertension and tachycardia. Hepatic encephalopathy typically presents with hypothermia, respiratory alkalosis, and relative hypotension. Fifth, perform careful neurologic examination. In metabolic encephalopathy, the pupillary reaction to light is usually preserved and symmetric, whereas a structural lesion may cause significant asymmetry or ipsilateral loss of pupillary reactions. This distinction alone can be diagnostically powerful. Motor phenomena in metabolic encephalopathy provide valuable clinical clues to the underlying etiology. Action postural tremors are commonly seen in patients with agitated delirium, withdrawal states, uremia, and in the early phases of hepatic encephalopathy. These tremors are typically irregular and asynchronous. Asterixis, also known as negative myoclonus, is a fascinating and clinically important finding. To elicit asterixis, we have the patient hold their arms outstretched with wrists dorsiflexed and fingers extended. The characteristic flapping tremor then appears, a brief, irregular loss of postural tone that causes the hand to drop and then return. Asterixis may also affect axial muscles, causing the head or body to drop forward. If supported in a frog-leg position, the lower limbs may also be affected. While asterixis is classically associated with hepatic encephalopathy, it is not specific to liver disease. It can occur with hypoxia, hypercarbia, and various electrolyte abnormalities, including hypokalemia and hypomagnesemia. Multifocal myoclonus represents a different motor phenomenon. These are brief twitches that occur in various muscles in an asynchronous, non-rhythmic fashion. They often involve the face and limbs and may migrate from one side to the other. Multifocal myoclonus can be seen in all stages of encephalopathy associated with renal failure, hepatic disease, electrolyte disturbances, and hyperthyroidism. In hepatic coma, multifocal myoclonus is usually an ominous sign and portends a poor prognosis. Recognizing these motor phenomena helps us narrow our differential diagnosis and guides our investigation towards specific etiologies. The neurologic examination, particularly focusing on pupillary reactions and eye movements, provides critical information for distinguishing metabolic from structural encephalopathy. In metabolic encephalopathy, the pupillary reaction to light is usually preserved and remains symmetric. This is a key finding. By contrast, structural lesions often cause significant asymmetry in pupillary size or reactivity, or ipsilateral loss of pupillary reactions. Regarding eye movements, roving eye movements can occur in metabolic encephalopathy and are generally benign. Rarely downward eye deviation can occur. However, lateral gaze deviation, skew deviation, and disconjugate eye movements are more suggestive of structural pathology. Hepatic encephalopathy deserves special mention because it can produce various false localizing signs that might suggest structural pathology. These include conjugate horizontal or vertical gaze deviations, disconjugate down gaze, severe spasticity with sustained clonus, and a variety of abnormal postures including decortication to painful stimuli. These signs may result from cerebral edema, but importantly, they can also occur with normal intracranial pressure and normal metabolic function. Hypoglycemia and hyperglycemia are particularly notorious for producing movement disorders, especially hemichoria, which can be easily mistaken for structural lesions. Wernicke encephalopathy related to thiamine deficiency commonly causes eye movement abnormalities, including loss of the vestibulo-ocular reflex. Importantly, parenteral thiamine usually restores the vestibulo-ocular reflex in these patients, providing both therapeutic benefit and diagnostic confirmation. These findings emphasize the importance of careful, systematic neurologic examination in patients with altered consciousness. The prognosis of metabolic encephalopathy is generally favorable compared to structural brain lesions, but several important caveats must be understood. While most metabolic disorders are inherently reversible, the clinical course can be protracted, and recovery times vary considerably depending on the underlying cause and the severity of illness. Potential complications include long-term disability and permanent cognitive impairment, even after successful treatment of the underlying metabolic derangement. Several factors independently predict outcome. These include the underlying etiology, the presence of critical illness, the severity of impaired consciousness, and the duration of coma. Sepsis-associated encephalopathy deserves particular attention. It affects up to 50% of patients hospitalized for sepsis. The mortality rate is significantly elevated, ranging from 26 to 49%. Patients with renal, liver, or multi-organ failure are more frequently affected than septic patients without organ dysfunction. For neurocritically ill patients, distinguishing delirium from metabolic encephalopathy can be challenging, but the pooled prevalence of both conditions is estimated at 12 to 43%. Importantly, delirium in neurocritically ill patients is associated with increased hospital length of stay and worse functional independence outcomes. These statistics underscore the clinical importance of early recognition and aggressive management of metabolic encephalopathy. Let me walk you through a fascinating case that illustrates the diagnostic principles we have discussed. An 87-year-old woman was admitted to the hospital from a chronic care facility. She was found unresponsive in her bed after failing to go to breakfast that morning. She briefly roused in the ambulance, but lapsed into coma by the time the ambulance arrived at the emergency room. On arrival, she was promptly intubated. Blood studies revealed a hemoglobin of 12 grams per liter, a white blood cell count of 5.8 times 10 to the 9th per liter with normal platelets. Blood gas analysis showed a pH of 7.18, indicating acidemia. The PaO2 was 60 millimeters of mercury, significantly low. The PaCO2 was 98 millimeters of mercury, dramatically elevated. The bicarbonate was 35 millimoles per liter. A CT scan of the head was performed and showed a heavily calcified basilar artery with no obvious lumen. The neurology service was consulted to consider thrombolysis for suspected basilar artery occlusion. However, detailed neurologic examination provided crucial clues. The patient's pupils were 3 millimeters and reactive. Corneal and vestibulo-ocular reflexes were brisk. Cough and gag reflexes were present with endotracheal suctioning. Muscle tone was normal. Deep tendon reflexes were 2+ except for absent ankle jerks. On general inspection, her skin was normal. There was no organomegaly. Heart sounds were normal, and the chest was clear to auscultation. Further investigation included nerve conduction studies and electromyography, which revealed normal motor and sensory conduction velocities and no evidence of neuromuscular junction pathology. However, phrenic nerve stimulation showed reduced diaphragmatic action potential amplitude, and needle electrode studies revealed abundant fasciculations and fibrillation potentials. A diagnosis of neurogenic diaphragmatic weakness was made, and motor neuron disease was considered as the most likely underlying condition. The key insight here is that the elevated serum bicarbonate concentration of 35 millimoles per liter with non-compensatory acidosis indicated acute decompensation of chronic respiratory failure. The patient had chronic respiratory failure with metabolic compensation, and acute worsening led to acute carbon dioxide narcosis. This case beautifully demonstrates how detailed neurologic examination can distinguish structural from metabolic lesions and how comprehensive investigation can identify the true etiology of coma. Understanding the etiologies of metabolic encephalopathy is crucial for targeted diagnosis and treatment. Let me begin with organ dysfunction, which represents the most common category. Hepatic disorders are the most frequent cause, including acute hepatic encephalopathy, chronic portal systemic encephalopathy, and various complications of hepatic encephalopathy. The mechanism is fascinating. In acute hepatic encephalopathy, the liver's ability to metabolize ammonia is impaired. Ammonia enters the astrocytes of the brain and combines with glutamate to form glutamine. This glutamine formation generates reactive oxygen species and subsequently causes astrocyte edema. This leads to alterations in GABAergic, dopaminergic, serotonergic, and glutaminergic neurotransmission, all of which contribute to the encephalopathy. Uremic disorders represent another major category, including acute renal failure, chronic renal failure, complications of renal transplant, and urea cycle disorders. The mechanism involves accumulation of products of protein metabolism and the kidney's inability to maintain homeostasis. Pulmonary disorders, including hypercarbia and hypoxemia, cause metabolic encephalopathy through multiple mechanisms. Hypoxia increases blood-brain barrier permeability, leading to cerebral edema. Hypercarbia affects the cerebrospinal fluid pH. Together, these factors impair cerebral function. These organ-based etiologies represent the most common causes of metabolic encephalopathy and should be systematically evaluated in every patient presenting with altered consciousness. Moving beyond organ dysfunction, we encounter systemic infections and endocrine disorders as major causes of metabolic encephalopathy. Sepsis is a particularly important systemic infection cause. The mechanism is complex. Inflammatory signals from sepsis reach the brain through a compromised blood-brain barrier. Afferent fibers of the vagus nerve are also activated. Astrocytes become activated, and continued infiltration of inflammatory cells causes injury to endothelial cells, leading to derangement of cerebral perfusion. The brain responds by initiating a neural reflex that promotes the release of neurotransmitters, which contribute to decreased counts and abnormal responses of peripheral immune cells. This creates a vicious cycle of neuroinflammation. Endocrine dysfunction represents another important category. Thyroid disease includes both hyperthyroid and hypothyroid states. Excess thyroid hormone causes neurotoxic effects and increased sympathetic tone. Thyroid deficiency causes reduced cerebral blood flow and metabolic dysfunction. Adrenal dysfunction can manifest as psychosis from excess cortisol or as gastrointestinal symptoms, orthostatic hypotension, electrolyte abnormality, and hypotensive shock from adrenal crisis. Glucose abnormalities are particularly important. Ketoacidosis impairs cerebral function through metabolic dysregulation. Hyperglycemia induces metabolic dysregulation during the state, mediating neuroinflammation and cerebral oxidative stress. Hypoglycemia can destroy superficial cortical neurons or cause secondary cerebral cortical injury. These endocrine and glucose abnormalities are often rapidly correctable, making their identification particularly important for patient outcomes. Nutritional deficiencies, electrolyte derangements, and medications represent important and often overlooked causes of metabolic encephalopathy. Vitamin B1 deficiency, which causes Wernicke encephalopathy, results from the inability of neuronal cells with low intracellular B1 to meet their metabolic demands. Vitamin B12 deficiency impairs the synthesis and maintenance of myelin sheaths, leading to neurologic dysfunction. Electrolyte imbalances are particularly important. Sodium abnormalities, calcium abnormalities, and magnesium abnormalities all lead to fluid shifts within glial cells, which play a significant role in the development of encephalopathy. Medications represent a frequently overlooked category. CNS depressants, anticholinergics, dopaminergics, and serotonergics can all cause drug-induced delirium through neurotransmitter imbalances. Polypharmacy deserves special attention. Increased numbers of medications are associated with cognitive impairment in older patients, even when none of the medications are themselves clearly linked to delirium or confusional states. This may result from adverse drug reactions or drug-drug interactions that are further exacerbated by renal and hepatic dysfunction. Gefepime, a fourth-generation cephalosporin, deserves specific mention. It activates GABA class A receptors, resulting in intracellular influx of chloride and can cause encephalopathy. These medication-related causes are often rapidly reversible upon discontinuation, making their identification particularly valuable for patient outcomes. Understanding the epidemiology of metabolic encephalopathy helps us appreciate its clinical significance and the importance of systematic screening. Because metabolic disorders are numerous and varied, overall incidence and prevalence figures are challenging to interpret. However, meta-analysis of available studies shows prevalence ranging from 4 to 31% of hospitalized patients. Importantly, prevalence is higher in hospitals than in general populations and is highest in intensive care units. Cohort studies have demonstrated that delirium, the most common manifestation of metabolic encephalopathy, is found in 60 to 80% of mechanically ventilated patients and 20 to 50% of non-ventilated patients. An observational study of 251 elderly patients followed over 1 year demonstrated that metabolic causes were responsible for encephalopathy in 84 patients, representing 33.47% of the cohort. Among those patients with metabolic encephalopathy, hyponatremia was the most common cause, followed by hypoglycemia. For neurocritically ill patients, distinguishing delirium from metabolic encephalopathy can be challenging, but the pooled prevalence of both conditions is estimated at 12 to 43%. These epidemiologic data underscore that metabolic encephalopathy is not rare. It is common and affects a substantial proportion of hospitalized patients, particularly those in intensive care settings. Prevention of metabolic encephalopathy begins with recognition. Impairments in consciousness should be promptly recognized and investigated because mortality and morbidity increase with increasing obtundation, reflecting greater severity of underlying illness. Several screening tools are available. The Confusion Assessment Method, or CAM, is a commonly used bedside test that allows for rapid identification of delirium. The standardized test consists of questions focusing on 3 key features: the acuity of onset, the fluctuating nature of behavior, and the level of attention. For intubated patients in the intensive care unit, the CAM ICU version may be used as it does not require verbal output. For patients with hepatic encephalopathy specifically, the hepatic encephalopathy scoring algorithm and West Haven criteria can be used to grade the severity of encephalopathy and help predict the patient's clinical trajectory. Research has also identified gender-specific risk factors for hepatic encephalopathy, theorized to be due to differences in body composition, gut microbiota, and adherence to therapy. Beyond screening, prevention requires prompt identification and correction of systemic derangements. Non-pharmacologic methods are particularly valuable. These include frequent reorientation of the patient to person, place, and time, optimization of sleep hygiene by providing darkness at night and illumination during the day, and conservative use of physical restraints. These simple measures can be very helpful in both prevention and management of delirium. Distinguishing metabolic encephalopathy from other causes of altered consciousness is essential for appropriate management. Several key differential diagnoses must be considered. First, consider degenerative diseases. The clinical course is typically more rapid with metabolic encephalopathies than with most degenerative disorders. Creutzfeldt-Jakob disease represents an important exception. Creutzfeldt-Jakob disease may be associated with focal signs, startle myoclonus, and lack of fluctuation, all features atypical for metabolic encephalopathy. Second, consider primary infectious diseases of the brain. These may have acute or subacute onset and are steadily progressive, helping distinguish them from the fluctuating course of metabolic encephalopathy. Infectious diseases typically present with fever, leukocytosis, and a systemic inflammatory response. Third, consider extracerebral mass lesions such as subdural hematomas. These may cause fluctuations in level of consciousness somewhat similar to metabolic encephalopathies. However, they usually also produce focal signs such as lateralized weakness. Acute confusional states associated with acute or chronic subdural hematomas may not have focal findings, but these patients typically have a history of trauma. Finally, consider structural brain lesions. These may present with non-focal symptoms such as confusion, memory problems, or personality changes. However, they often result in focal deficits such as hemiparesis, which would be unusual in pure metabolic encephalopathy. Careful history, examination, and imaging help distinguish these entities. Many intoxications present with features that mimic metabolic encephalopathies. These intoxications typically spare the cranial nerve reflexes and produce a dose-dependent depression in level of consciousness. However, several key features can help distinguish specific intoxications. Sedative drug intoxication can selectively and reversibly abolish the vestibulo-ocular reflex, a helpful diagnostic clue. Massive doses of barbiturates can abolish pupillary and other cranial nerve reflexes and cause apnea, mimicking brain death. This is a critical distinction because it affects decisions about organ donation and end-of-life care. Drugs with anticholinergic effects, including tricyclic antidepressants or atropine used during resuscitation, can transiently produce dilated, unreactive pupils to both light and accommodation. Hyperventilation can mimic the metabolic acidosis seen with renal failure, lactate accumulation, or diabetic ketoacidosis. This hyperventilation can be produced by exogenous agents such as methanol, ethylene glycol, and aspirin. Methanol is metabolized to formic acid, which is present as the formate ion via formaldehyde. Ethylene glycol is metabolized to oxalic acid. Salicylate assays are available to screen for aspirin poisoning. Ethylene glycol, commonly found in antifreeze, is often manufactured with a fluorescent tag that can be detected in the urine with a Wood's ultraviolet lamp. These specific diagnostic clues enable rapid identification of intoxications and guide appropriate treatment. The diagnostic workup of metabolic encephalopathy begins with the fundamentals, history, and examination. The first and most important step is obtaining an accurate, thorough history, followed by a comprehensive examination. In comatose patients, the history is obtained from relatives, friends, eyewitnesses, or by phone if necessary. Obtaining collateral information from witnesses is very important because patients with metabolic encephalopathy are often unable to provide accurate recollection of preceding events. Specific details to ascertain include the acuity of presentation, the patient's baseline mental status, prior medical and social history, cancer history, profound depression, drug or alcohol abuse, and underlying illnesses such as diabetes, mellitus, pulmonary disease, hepatic disease, or kidney disease. Once history is obtained, we proceed with laboratory studies. A comprehensive metabolic panel should be obtained, including electrolytes, glucose, kidney and liver function tests, and especially ammonia levels. Thyroid function tests are essential as both hyperthyroidism and hypothyroidism can cause encephalopathy. Arterial or capillary blood gas determination can be very helpful in the presence of hyperventilation, hypoxemia, and for identifying specific toxidromes. A complete blood count should be obtained to exclude leukocytosis, which would suggest infection. These laboratory studies, combined with careful history and examination, form the foundation of the diagnostic workup. Continuing the diagnostic workup, we order urine studies and imaging. A urine drug screen should be ordered to assess for the presence of toxic substances or their metabolites. This includes screening for alcohol, benzodiazepines, barbiturates, opiates, cocaine, amphetamines, tricyclic antidepressants, salicylates, and acetaminophen. Imaging studies are helpful to rule out structural lesions such as intracranial hematoma or mass lesion. In a study of patients with cancer presenting with altered mental status, a structural brain lesion was the sole cause of encephalopathy in only 15% of patients, emphasizing that metabolic causes are more common. Specific imaging findings can point toward particular etiologies. Diffusion-weighted imaging has disclosed characteristic features of acute hepatic encephalopathy, including restricted diffusion in the thalamus and cortex bilaterally. Characteristic lesions in the putamen and globus pallidus can suggest methanol and carbon monoxide toxicity, respectively. Nuclear magnetic resonance spectroscopy can help confirm Wernicke encephalopathy, with changes occurring in the mammillary bodies, periaqueductal gray matter, the collicular bodies, and the medial thalamus. Importantly, diffusion-weighted changes involving the cortex appear to indicate irreversible damage, whereas white matter changes are reversible in hypoglycemic coma. Electroencephalography is particularly valuable. EEG is helpful to evaluate for subclinical seizures, but can also be used to grade the severity of encephalopathy. Metabolic dysfunction secondary to renal and hepatic failure have been identified as risk factors for non-convulsive status epilepticus. These diagnostic tools, used systematically, enable identification of the underlying etiology and guide targeted treatment. Electroencephalography provides valuable diagnostic information in metabolic encephalopathy. The main clinical role of EEG is to evaluate for subclinical seizures, but it can also be used to grade the severity of encephalopathy. Certain EEG patterns are characteristic of metabolic dysfunction. Triphasic waves or generalized frontally predominant rhythmic delta activity at 4 Hz or less on a slow or low voltage background are common features. Sepsis typically shows triphasic waves. Hepatic encephalopathy typically shows triphasic waves. Uremic encephalopathy shows triphasic waves or epileptiform activity, in some cases with photosensitivity in others. Wernicke encephalopathy shows sharp and slow wave complexes with periods of suppression in very advanced cases. Hypoglycemic encephalopathy shows diffuse slowing of the waking background frequency. Hyperglycemic encephalopathy shows mixed faster frequency with some focal epileptiform discharges. As glucose levels rise above 400 mg per deciliter, diffuse delta activity with sporadic spikes appears. Hyponatremia shows diffuse delta activity with alpha rhythms interrupted by bursts of high-voltage rhythmic delta activity. Hyponatremia shows progressive slowing of background EEG frequencies. Hypocalcemia may show generalized spikes and sharp waves, bursts of delta activity with sharp components, and some reports of absence status. Hypercalcemia may show excessive theta activity, fast activity, and bursts of delta and theta slowing. These specific EEG patterns, when recognized, provide valuable diagnostic clues that help identify the underlying metabolic derangement. Advanced diagnostic modalities can provide additional confirmation of specific metabolic etiologies. Cerebrospinal fluid analysis may be considered, but is primarily used to exclude the possibility of subarachnoid hemorrhage or CNS infection, such as encephalitis or meningitis. In some cases, CSF analysis may be helpful in evaluating for potential inflammatory, neoplastic, or paraneoplastic etiologies. Master brain spectroscopy, though not commonly available, can be used to detect specific causes of metabolic encephalopathy. For hepatic encephalopathy specifically, decreased myoinositol and choline intensity with increased intensity of the glutamine signal has been reported. These MR spectroscopy findings can provide additional diagnostic confirmation and help guide targeted treatment strategies. While these advanced modalities are not routinely available in all centers, they represent valuable tools when the diagnosis remains uncertain despite comprehensive conventional workup. The management of metabolic encephalopathy begins with general principles that apply to all patients. First, we provide medical stabilization. Second, we promptly diagnose and treat the underlying condition leading to encephalopathy. This requires a thorough review of the patient's medications, laboratory values, and medical condition. All potentially sedating medications should be discontinued. During the hospital course, careful observation for and treatment of superimposed infection or other factors that can potentially worsen symptoms are essential. For patients with hepatic encephalopathy specifically, medications which either decrease ammonia production or increase ammonia removal are the mainstays of treatment. Beyond etiology-specific treatment, neuroprotective measures have been shown to be helpful. These include treatment of fevers, control of mean arterial blood pressure, careful monitoring of glucose and sodium levels, and avoidance of hypercarbia and severe hypocarbia. These general principles, applied systematically, form the foundation of effective management. The treatment of delirium requires a balanced approach combining non-pharmacologic and pharmacologic strategies. Non-pharmacologic methods should be the first line of intervention. These include frequent reorientation of the patient to person, place, and time, optimization of sleep hygiene by providing darkness at night and illumination during the day, and conservative use of physical restraints. These simple measures can be very effective. When pharmacologic intervention is necessary, we must be judicious. Heavy or repeated doses of benzodiazepines should be avoided, as these drugs can contribute to encephalopathy and prolong intensive care unit stay. If neuroleptics must be used, it is important to closely monitor for extrapyramidal symptoms, especially in the elderly and those with a history of Parkinsonism. Certain neuroleptics such as olanzapine and quetiapine are associated with fewer side effects and may be considered in those with severe psychosis or a hyperactive form of encephalopathy. Dexmedetomidine may also be considered in cases of severe psychomotor agitation. The key principle is to use the minimum necessary pharmacologic intervention while maximizing non-pharmacologic strategies. Metabolic encephalopathy in pregnancy presents unique challenges and requires consideration of pregnancy-specific etiologies. Acute liver failure in pregnancy associated with encephalopathy occurs in two contexts. First, severe preeclampsia, particularly the HELP syndrome, which stands for hemolysis, elevated liver enzymes, and low platelets, can result in multi-organ involvement and cerebral dysfunction, most commonly in the second and third trimesters. Second, acute fatty liver of pregnancy can present in the third trimester with rapid onset encephalopathy and liver failure, requiring immediate delivery, as this decompensated liver failure can quickly lead to multi-organ failure. Beyond hepatic causes, other metabolic derangements can cause encephalopathy in pregnant patients. Hyponatremia is more common due to normal physiological changes during pregnancy and is also related to oxytocin release in the intrapartum phase. Hypercalcemia in pregnancy is most likely related to primary hyperparathyroidism, occurring at an incidence of 0.05%. Hyperemesis gravidarum affects 0.3 to 3.6% of pregnant women and is defined by persistent and excessive vomiting resulting in dehydration and weight loss. Patients with hyperemesis gravidarum can develop thiamine deficiency, leading to Wernicke encephalopathy and other electrolyte disturbances such as hyponatremia and hypokalemia. Recognizing these pregnancy-specific causes is essential for appropriate management. The COVID-19 pandemic has highlighted an important and common manifestation of metabolic encephalopathy. Cognitive changes ranging from agitation to severe encephalopathy requiring aggressive sedation are seen in 31 to 65% of hospitalized patients with coronavirus disease 2019. In one large series of 4,491 hospitalized patients with COVID-19, 12% had toxic metabolic encephalopathy. The most common etiologies were septic, hypoxic-ischemic, and uremic encephalopathy. Risk factors for development of COVID-19 related encephalopathy include age, underlying cognitive impairment, prior psychiatric disease, need for intubation, and cerebrovascular disease. The exact mechanism is not well understood but is thought to be multifactorial. It includes hypoxia from respiratory compromise, metabolic derangements, and systemic infection with the inflammatory cascade. cytokine-mediated inflammation involving interleukin-1, interleukin-6, tumor necrosis factor alpha, and others, increased blood-brain barrier permeability and hypercoagulability. This leads to stroke, which in combination with ARDS-associated hypoxemia further results in downstream inflammation, neuronal ischemia, and necrosis. Generalized slowing is often seen on EEG, reflecting a diffuse cortical process that may be driven by metabolic and/or hypoxic encephalopathy. In a meta-analysis of 12 studies characterizing EEG findings in 308 patients with COVID-19 infection, 96% demonstrated abnormal background activity, 92% had generalized slowing, and 20% had epileptiform discharges. With respect to management, low-potency neuroleptics and alpha-2 adrenergic agents are helpful in treating neuropsychiatric symptoms associated with COVID-19. As we conclude this comprehensive lecture on metabolic encephalopathy and metabolic coma, let me emphasize the key takeaways. First, metabolic encephalopathy is a common cause of altered consciousness in hospitalized patients, particularly in intensive care settings. It affects a substantial proportion of patients and is often under-recognized. Second, early recognition through systematic clinical assessment and rapid diagnostic workup are essential for improving outcomes. Third, the clinical presentation exists on a spectrum from mild confusion to profound coma, with delirium as the most common initial manifestation. Understanding this spectrum helps us recognize early disease and intervene promptly. Fourth, distinguishing metabolic from structural causes relies on careful history, examination, and selective use of imaging and laboratory studies. This distinction fundamentally changes our diagnostic and therapeutic approach. Fifth, management focuses on identifying and treating the underlying metabolic derangement while providing supportive care and avoiding sedating medications when possible. Sixth, prognosis is generally favorable when the underlying cause is identified and treated promptly, though complications and long-term cognitive impairment can occur. Finally, prevention through systematic screening and non-pharmacologic interventions is more effective than treatment after encephalopathy develops. By applying these principles systematically, we can improve outcomes for our patients with metabolic encephalopathy. Thank you for your attention throughout this comprehensive lecture on metabolic encephalopathy and metabolic coma. We have covered the definition and clinical manifestations, explored the underlying biological mechanisms, mastered the diagnostic workup, and learned evidence-based management strategies. The material presented is based on current medical literature and clinical experience. I encourage you to review the references provided and to continue learning about this important and common clinical syndrome. Metabolic encephalopathy represents a challenge to clinicians, but with systematic evaluation and targeted treatment, we can restore consciousness and prevent long-term complications. Thank you, and I welcome your questions and discussion.